Everybody's so pumped to be here. Yeah, okay, I like it. So for those of you that don't know me, I'm Zoe Powell. I am the manager for cardiac rehab here at McKD, as well as Layton and Bear River. So we're gonna do like a little optional tour and come see our gym afterward if you want to kind of get to know us a little better and that kind of stuff. If you didn't see our little housekeeping notes, we do have restrooms down the hallway on your right. And we just ask that if you have a phone on, please silence it. And for everyone on the call, if you can keep your mics muted, that would be wonderful. We'll do questions through the chat and keep a close eye on that. I'm going to turn it over to Jason Buckway just to get things rolling. If you have questions, let me know.
I wanted to take a minute to, first of all, introduce myself. My name is Jason Buckway. I'm the service line director for the Canyons region that oversees cardiac rehab. In that role, for the last 20 years or so, I've kind of been your spokesperson to administration. So when there are things that need to be dealt with, they generally start with our domain meeting and then escalate up to me. But I don't know all of you. And so I wanted to take 2 seconds to introduce myself. My background's nursing. I've been with Intermountain for now 33 years. And the whole time that I've been with cardiac rehab, we have done this annual meeting. Even through the pandemic, we were able to pull this off. So I think we're somewhere in our 25th, and maybe George could help me out, but somewhere in the 20 plus years of doing this conference. So congratulations to all of you, and thanks for being here. This is also the first year we have our Peaks colleagues. If you can raise your hand, made their way in from Denver. So we're grateful that they were able to join us today. So I'm here all day and I'd love to get to know some of you or all of you. So please feel free to swing on by and introduce yourself. So thanks for being here. I have the pleasure of introducing and welcoming Viet Lee. Viet and I know each other quite well. He and I spent a few days in Las Vegas when Viet was speaking for one of the conferences. And our claim to fame is walking off the elevator, and Viet ran into the knee of one of the NBA basketball players. And so it literally was, he was up here and Viet's forehead smacked him right in the kneecap. So that's our claim to fame. But Viet is an absolutely amazing advanced practice provider. I'll let him introduce himself, but he's very humble. So I'll say this, that he was nominated and awarded the nation's top APP director or APP for the United States. And he currently sits as the, I think, president of one of the associations. So Viet, I'll let you take from there so I don't slaughter it too anymore. But thank you for all being here, and I'll turn the time over to Viet Lee.
Okay, so let's see if I can share my screen here. I'm gonna, there we go. And hopefully you can see that okay. Great, and let's see, okay. So, spontaneous coronary artery dissection. I'm just, look, my roots come out from cardiac rehab. My undergraduate degree is in exercise science and athletic training, and I was an athletic trainer before applying and getting into PA school at the University of Utah. But during that time, I also worked, yes, during PA school, I worked on weekends in the cardiac rehab program at LDS Hospital. And this is a group that's near and dear, and really at the, no pun intended, at the heart of how I practice because of all the things that we did together in teaching and moving patients along to recovery. It's one thing to place stents, provide medications, etc., but it's another thing to really help folks get to life again. And so it's just an honor to be able to be back amongst you and talk about spontaneous coronary artery dissection. This is an important disease that we miss often. And in fact, just here at IMED recently, we had a young person have a SCAD event, and it's no joke, and of course it's not small to say that this is life-changing when you are not even really deep into your 20s and you have this event occur. So let's see if we can move forward here. I'm going to get rid of that cursor on my screen. Okay, so just some disclosures. I've been around a little bit, so I am on the ad board, or have been on an advisory board for Amarin, Idorsia, Novartis, Pfizer. I currently have some research support for peripheral arterial disease, a talk that I've given also amongst our colleagues here. But there's not too many things directly involved with those here, but some maybe off-label use, but I doubt it in this talk. So some objectives. You might not be too familiar with SCAD, and so we'll go through some basic physiology and some theoretical pathophysiology of SCAD. We just don't know everything, and we'll never really know everything, but we'll have a running start here. So we'll look at some cases and review the clinical presentations so that you can kind of get a grasp of what it looks like acutely as they transition to you, both on the inpatient floor and then in the outpatient services. But we'll look at those troponins and then what invasive or non-invasive imaging is part of this process. We'll look at some of those risk factors because you're going to get those questions. You've already received those questions. Why? Why did this happen to me? What makes me different? Did I do something wrong? How did I get this SCAD event? And then we'll review the role. I think, of course, that's the most important part, is how does cardiac rehab really help our community members that suffer from SCAD to move forward? Okay, so I put some things in the chat, some polls. Those that are there live probably didn't see that. Those online, hopefully you had a chance to look at those. Teams is funny, so if you enter late, you might not see earlier chat pieces. But I wanted to get you thinking about both some of the recommendations that we talk about in terms of what SCAD patients can and can't do, and then the realities of what patients face, because predominantly this affects women, young women. So here are the below guidance numbers from, excuse me, AACVPR. Are they for everyone? If we're looking for trying to get SVP or systolic blood pressure less than 140, diastolic less than 90, a response less than 20 during exercise, I think running up the stairs to get my Diet Mountain Dew, my heart rate and my blood pressure probably went through the roof. That's just me moving my own body up. Target heart rate of 70 to 80%. Any restrictions in general with exercise. And then, maybe a thought here is SCAD related to anxiety and depression. And we don't know. How much do we know? Okay. So SCAD, it's not coronary atherosclerosis. Here on your right is what we think of as coronary atherosclerosis. Now, it's still a heart attack in terms of damage to the heart, infarction that can occur when you stop blood flow. But it's not an atherosclerotic event from plaque. This is a dissection here along the lines, and let's see if I can get a laser pointer going through. So here's that lumen that's been peeled up, and now blood is going into this false lumen instead of the true lumen here. Whereas again, in coronary artery disease, this is a plaque rupture event. Okay, so the different types of SCAD that we look at, up here what you're seeing is, excuse me, IVUS or intravascular ultrasound. And, it takes a catheter. Here's the catheter poked inwards. You're seeing the true lumen right here. And then, holy moly, look at that, all that blood that's sitting in this false lumen up above. Same thing over here in type 3. Again, you got all this blood sitting in that false lumen, but it's the way that it courses through that we call it type 1 or 2 or 3, where it's focal instead of, kind of this longer looking lesion here. Okay, so Again, just more of a graphic figure of what type 1, 2, and 3 are. I've given you the references here if you want to go look. And then, most of you are familiar with where right coronary, left anterior descending, left circumflex all sit. But again, just wanted to kind of show you, and then the kind of the terminology and adjectives we think about for type 1 through 3. Just again, I'm hitting on the point because it takes a lot of different views and images for me anyways, to set in what this pathophysiology is and what it looks like. On this angiogram, I mean, you're looking at this bifurcation where the the artery is starting to split off one way or the other, and it's stenosed, right? It's narrowed through here in multiple focal areas. And why? How do we know this is SCAD? Well, I mean, gosh, you could drive a car through this road until it just suddenly drops off, and it doesn't look ectatic. There's not a lot of diffuse atherosclerotic plaque going on. The highway looks pretty good, except for these really focal looking SCAD dissections. And so that's why it has such a pathognomonic look to it, where everything else looks pretty good. An atherosclerotic lesion here, usually we see kind of this ratty, tatty, diffuse looking areas of blockages that aren't fully stopping the dye from going through. But you've got this really beautiful, healthy looking artery, and then suddenly it just kind of dissects and stops off there, and again in this spot. So this is what we're seeing, is these areas within where the dissection has occurred. And we'll talk about why this is different from this, and then finally this, where it's had an intimal tear. So where did it start? Is it because the flap tore and then blood gets through into that sidewall? Or is it because there's a hemorrhage within the sidewall that then pushes and pushes together and then ruptures through? That's the question. So we'll look through a case here. Here's a 70-year-old woman who experienced sudden onset chest pain. And really, this sounds like atherosclerosis when you think about how the presentation is. So the traditional kind of STEMI or N-STEMI. EMS arrives, learns that the day before she had choked on some food. She received the Heimlich maneuver with success, so dislodged the food. She was seen later in the evening at the Instacare because she had ongoing chest pain. And you're thinking, wow, someone Heimlicked her, maybe her ribs fractured. She's 70 years old, and she has this sudden chest and mild jaw pain. Took some aspirin, visited the neighbor, and that neighbor called EMS. And then this is the EKG that you see below. And, to your eye, you should notice a few things here, right? There's a little bit of some ischemic changes looking in inferior, one in AVL, that's lateral, and then inferior 2, 3, and AVF. Well, you shouldn't be able to mistake a STEMI. Here it is, 2, 3, and AVF, this inferior looking MI. And most of us would probably think, wow, that's probably right coronary artery because that wraps around that inferior portion in most people. So I'm kind of, teeing it up for a little bit of a different looking angiogram maybe. But here, what you see is the initial troponin is 0.01, and then it floats to 0.21. So here we go, okay, there's myocardial injury going on. This is consistent with this EKG with a STEMI in 2-3 AVF. Just a reminder of what coronary angiography is, because she was taken right to the lab. STEMI protocol was activated. And so, this is a little bit older femoral approach. Typically now we go into the left, the right radial artery, and they come up through this process into where the left main and RCA is. So they'll loop around, and so again, this is not quite correct to what we do most of the time now. It will be coming from this side over here, up and over and then down. But you can see the right coronary arteries, and here they just depict left, anterior descending stenosis there. Here again, just to show you that same picture from that last slide, here's RCA, and so they've put the catheter down and they poked it here first. And again, the STEMI is 2-3 AVF, so they're thinking right coronary artery. Let's check out that side. We think that's where it's going to be. And so they poke right over here, they blow the contrast, and they go, well, actually, this is a really non-dominant right coronary artery. So what's the deal here? We don't see a lesion, and furthermore, we probably will see that the left circumflex is quite dominant and will cover that same territory where 2-3 AVF will be. So they go, okay, we can look on the other side. And that's what they do here. They pop over to the left side, and here left anterior descending, and then the left circumflex starts right at this point. And as you go down, lo and behold, look at this area. But again, SCAD or atherosclerosis. Look how beautiful all these arteries are. There's no atherosclerotic looking lesions. It's not ectatic. This is a beautiful looking left circumflex, but boom, you've got just this bite out of that obtuse marginal artery. And so that's really what's happened is LAD looks great. Left circumflex here, you get this, and they've just turned the camera so that you can now see on fluoroscopy from a lateral view here. And so left circumflex looks great, but that's that same lesion here that was on this side. And excuse me, so here's the wire, and I'm pointing to this space because just distal to where that dissection is staining. You see the staining that was right in that spot, and so it's bleeding into that space. And so again, these are the features that the interventionalist is taking a peek at and going, yep, we've got, I mean, not that this wasn't already like, oh, we've got a problem, but that staining gives you some more clues as to what you're looking at. Okay, so this is that same angiogram. There's left anterior descending, here's left circumflex, here's that obtuse marginal, but they've ballooned it. Here's that balloon, and actually you may or may not be able to see the stent structure there, but they've deployed a stent. Here's the catheter wire that anchors this whole process there. And so the next one here, as they deflate the balloon, you should be able to see kind of that visual image of the stent structure behind. And then, darn it. Anyways, what they've done, this is the same picture here with the balloon deflated, and now they've put contrast in, and you can see how much better that flow is through here. Now there's a slight, might have gone a little bit distal to where it should have been, but nonetheless, the rest of where that dissection was is now having blood flow through that space from that stent. Okay, so they didn't echo because they're like, ooh, geez, STEMI in that inferior end, is there any problems? Here's the resting diastolic phase, and then in the systolic phase, and you get an ejection fraction of 63%, right? So we were like, oh, okay, this she's preserved her LV function. You don't see it here because I don't have any cines moving pictures, but there was no akinesis or anything like that. They actually got to her in time, and there was no akinesis or hypokinesis. And usually if you see that, it's because the myocardium has been stunned just a little bit, and you do a repeat echo, and usually that sorts itself out. So here was the EKG evolution. And I wanted just to see, look at the pre-event. She had an EKG a few years back, and so 2-3 AVF, right? We had something to look at, and it all looked essentially normal. And then EKG at presentation. So it's always nice to be able to look back. You should take that moment. Cardiac rehab colleagues, do this in any patient that you're treating. It's good for you to see if they have a pre-EKG or pre-event EKG to go, yeah, oh, okay, this, it sets it in, it becomes real, and as you explain this to the patient, it's so much easier than to show them that pre and during, so that they understand what a STEMI really is and specifically what that looked like for them. So again, as we kind of run through this process for this patient, this was the EKG at presentation, so moving it forward from that last slide, and you can see it day one, again, 0.01, and then a couple hours later, 0.21. The next day, just a couple hours later into the night, 2.74, and she crests at 15.65 throughout that next day and starts to come down after that stent, okay? And then 3 months later is less than 0.01. But this is what it looks like 3 hours later from stent. I'm always, I'm often asked, because I have a current EKG phase 3 clinical trial, like, we capture an EKG after stent has been placed for STEMI, and folks are like, oh no, you can't do that afterwards, the STEMI is gone. This is 3 hours later, okay? It's not as high, but you can still see the STEMI. So someone's got their audio on and it's gonna keep echoing here. There you go. All right, so here's the STEMI at 3 hours later, and that's after the stent. So folks, it doesn't resolve very quickly, but it resolves because here it is 2 days later. Okay, it's going through that evolution of from STEMI. Now that myocardium is starting to heal and regain blood flow, and this is 3 months later. Okay, so it's not entirely normal from the pre-event EKG, but at least at 3 months, it is starting to come back and evolve. So I just wanted you to see, here's the pre-event, here's EKG at presentation, and then now 2 years later. And you can see that it's almost back to normal if you're going back to pre-event and then 2 years. So it's kind of fun to think about these cases and say, well, she survived, but also cardiac rehab, I'm hopeful and I think that you probably were part of this process for her. Okay, so a case that's it's striking. I think about this like sudden cardiac death on a sports event field. It's tragic, A, because there's a death, but B, because folks are so young. At 19, you would expect, at least another 50, 60 years of life, right? So here's a 19-year-old woman who developed abrupt chest pain walking home from dance class. Front of her chest, radiating to the back, down both arms. She had had a recent COVID-19 infection 6 weeks prior, and they thought, oh, maybe this is myopericarditis. This is her EKG on presentation, and in fact, this is STEMI all over the place. So yeah, why shouldn't it be presumed as myopericarditis? Typically, we see STEMI in terms of a region just in one area, RCA or LAD or whatever, but this is transcardiac EKG. She's got STEMI all over the place, and so this is what we typically see in pericarditis or myocarditis. And that, with this COVID-19 infection, they thought, okay, this is myopericarditis. So troponins continue to increase. This was her echo that they did initially. What you'll see here is, there we go. The laser pointer is going to catch up to me here. There's this pocket of fluid in the pericardial sac here. My computer system is slow enough that this is not tracking. I'm in the left ventricle here, and up above here is the left atrium. So it's kind of on this long axis here. But there's the effusion. And so, they're like, yeah, of course, this clinical picture looks like myopericarditis, but no tamponade. And this is the initial day one EKG, troponin. And you're like, wow, that last gal, her highest was 15 in terms of troponin, and it's marching up 0.11, 18, 24. This is the first day within hours. And then day 2, 87, 114, day 3, 228. There's quite a bit of myocardium that's been damaged for this young woman. So, the angiogram was completed. Here's the LAD. Here is left circumflex as it comes down. She had just this massive area of dissection through this space, and it was proximal, left anterior descending. She had a couple other spots where there was some dissection as well. So they decided close monitoring. CT surgery was consulted, and they said, look, this is extensive. There's a lot of myonecrosis. So if we go in there, it's kind of like, it's kind of like trying to plant grass in an area that's been devastated by fire, and you just don't have anything for it to hang on to. So they wanted to wait. Medical management after the acute MI was started. So they had anticoagulation. She was on unfractionated heparin. Tirofiban was also included. And then low-dose aspirin. They weren't quite sure what else to do, but added P2Y12 anyways as part of her antithrombosis regimen, and then started beta blockers, ACE, and adjusted that. So here was her day 2. Again, remember, she had kind of this STEMI looking picture, and day 3, things were kind of flattening out. She's got Q waves here in the anterior section. 2 months later, look how deep these Q waves are across the anterior portion of her heart. She had a cardiac MRI 3 months later, and her LV function went from 50 down to 35%. And in that left ventricle, there was just this large scar burden. She had apical clot, and just nothing was moving. So this is what a normal cardiac MRI looks like. You can see the squeeze here, just nice and 50+%. And then this is abnormal. That's just not moving, really. There's just no motion going on in this distal section. And this is apical akinesis. You can imagine if it's not moving down there, then clot just continues to form down here. You can see blood flow, yes, but it's not moving very well through here. So despite medical therapies, carvedilol, spironolactone, losartan, her EF remained low, and the decision was to place a defibrillator in this 19-year-old because she is at high risk for sudden cardiac death after this SCAD event. Okay, so what's the epidemiology of SCAD? I've been kind of a downer through these cases, but let's talk about it, right? It's predominantly occurring in women of less than 50 years of age, so 1 in 3 of acute coronary syndrome in women less than 50 years of age can be SCAD. It's most commonly caused during pregnancy, let me say that again. The most common cause of pregnancy-associated heart attack is SCAD, about 43%, so half of these. When we see a woman present with heart attack, it's SCAD. Average age is between 45 to 53 years of age. She definitely was much younger at 19, and our other case was 70, so they bridged both sides of this. Any artery can be affected, but it's most commonly the LAD, about 46% of the cases. And then less than 10% are proximal. Hers was, right? This was a proximal LAD, but they're 1 in 10 or less that occurs. But multiple SCAD in vessels, multiple vessels can be affected as well, from 1 in 10 to 1 in 5 of those cases. So it's not like rare to have multiple vessels. So thoughts to how this occurs or why this occurs. Here we have a regular artery. Here's the true lumen. Here's the intimal layer, and then the media, and then adventitial layers. So the question is it a tear that high blood pressure happens to flow down that true lumen and then just hits the side wall? Think of water pressure or high pressure why am I missing my words here? For car wash, and yeah, you're up against metal, fine. But imagine moving that across grass and how that will just tear that up and slice your grass up. So high pressure can rip through the sidewall, that intimal layer, and then blood, regular, normal blood coming through will then fill that space. So it'll cause that false lumen. Or is it a spontaneous rupture of the vasa vasorum, the little capillaries and arterial system within that medial layer? It ruptures and causes hemorrhage and then causes it to fill up, ultimately either rupturing or causing a blockage where the two ends, as it wraps around, blocks off blood flow. So it's a combination of factors. It can be a perfect storm, not any one thing per se, but maybe all of these things or enough of these things come together. So the most common SCAD-associated arteriopathy is fibromuscular dysplasia. This is inherited. It's a mutation of the connective tissue, and just imagine. I guess like the Boeing 747, where someone on the line just isn't checking bolts, and that's a mutation, and it's will the door fly off the airplane in the middle of the flight? That's going to be a mutation. We don't know, but there's a high risk for it, right? Can occur in any arterial region. Prevalence in SCAD ranges. It's a wide range, partly because we just don't recognize this enough to get an appropriate percent of how prevalent it is with FMD, with fibromuscular dysplasia. But you can see this kind of mother of pearls or string of pearls, not mother of pearls, string of pearls look that FMD has, and why dissection then may occur, because that connective tissue is just faulty. It's really not holding together well. So then there's pregnancy-associated SCAD. And this is, the majority of these events when SCAD occurs in pregnancy is in that third trimester. I mean, imagine there's so much blood volume that the mother takes on to try and support this growing infant, or fetus, rather, not infant, but fetus inside her. And so a lot of blood pressure, a lot of things are going on. So left main, or LAD, sorry, not left main of LAD, but left main or LAD. We know this is a problem, right? This is a huge issue. Left main supplies both left circumflex and LAD, but LAD itself also supplies that left ventricle. And so it's problematic. The average age here is 33 to 36, so a little bit older for pregnancy in general. But it's more common in blacks, chronic hypertensives, folks that have lipid abnormalities. So the chronic depression, who knows? These are the kind of the comorbid conditions that we identify when someone has SCAD in pregnancy, migraines, advanced maternal age. I wouldn't call you advanced age, but of course, as we think of when women are having children, it is advanced in terms of when folks tend to get pregnant, and in infertility treatment, but also chronologically and biologically. That's quite the stress test for the body. So PSCAD, or pregnancy SCAD, has a poor prognosis. This is terrible. 3/4 present with STEMI. We know that STEMI has a higher mortality rate. 1/4 of them are in cardiogenic shock when they present. 1/4 require mechanical support. 15 have ventricular fibrillation, 15%, and then 4% in hospital death. And mortality rates are increasing for women here in the United States for all different reasons, but here, PSCAD does contribute to this. So other factors, as we talked about mutations, so other connective tissue disorders are part of this, but they're less than 5% of SCAD. And over here you can see connective tissue disorders that are a little bit more visible. You can imagine that translates a little bit to the arteries, the valves, etc. So Ehlers-Danlos, Marfan's, Loeys-Dietz, SCAD is still just under and misdiagnosed. So it's really difficult to assess the true genetic involvement or inheritance here. It occurs in extreme physical or emotional distress. There is recall bias. And again, this is where I'm going to go off on a tangent just for a second. This is where it's so difficult for a nutrition science, from decade to decade. Eggs are good, eggs are bad, salt is good, salt is bad, diet soda is good, because we're relying on recall. I challenge you to remember over the last 5 years what you ate for, each day, let alone each week, month, and then this past week. So it's very difficult, but we're relying on recall bias as to folks' history. So recall bias is less prominent in terms of confounding information, as we have a primary treating center like Intermountain Medical Center. So we get the information at the time that we are treating these patients, and Intermountain Medical Center is part of the SCAD registry, the national registry, and then Dr. James Orford is the principal investigator of that. We have a local registry as well that I've been part of, and we started about 6 or 7 years ago. So this is the typical presentation. It's acute coronary syndrome, right? It's acute coronary syndrome, and by and large, chest pain is the highest presenting symptoms, but look at all the things that also are presenting in these women, or men and women. They have typically elevated cardiac enzymes. Depends on when you catch them in this process. Non-specific ST wave is seen on EKG and often converts to STEMI when things go south, and then 2 to 5% in cardiogenic shock. We saw that higher for PSCAD. It was 15%, or excuse me, a quarter of them, so 25%. 3 to 11 ventricular arrhythmias or sudden cardiac death, and then same atypical features that we see with acute coronary syndrome. So dizziness, heartburn-like, cold sweats, etc. So you can't ignore those symptoms. Please don't. Here, Dr. Kent Meredith has done a great job in the STEMI program over the last 15 years and has instituted nose to navel. Any symptoms between the nose and the navel should prompt an EKG. It really just don't miss a STEMI. Okay, so here's the diagnosis. We use imaging that's non-invasive or invasive. Often it's coronary angiography, but you'll see in the algorithm that we use non-invasive testing as well, cardiac MRI, coronary CT angiograms, and then of course we've talked about the classification scheme. The problem with invasive angiography is that just like we talked about with a water pressure gun across grass, you are squirting dye into a coronary artery, and if that catheter wire is close to the wall, or there's just a little bit of an abnormality on that coronary artery wall, you can dissect the artery. But even the catheter wire, as you're kind of poking down there, it can catch an edge and cause dissection. So intracoronary imaging, we'll talk about IVUS, intravascular ultrasound, or OCT, optical coherence tomography. So here's IVUS, and it looks kind of crazy, this big eye looking at you, but what you're seeing here is the entire coronary artery, maybe, except you're not, because there's the hematoma, and this is now the true lumen. And this is where the hemorrhaging is in the hematoma, and this is where the coronary artery should be, but there's where the intima has been pushed inwards. Okay. Here, this is IVUS or OCT. This is kind of the look that you see, and again, what you're seeing is the coronary artery, and then here is actually where the coronary artery has collapsed into. So the true lumen, the intima, has squished down because now this is all that hematoma in that space. Same thing here. So you'll start to get kind of an idea of how this looks. Okay, so coronary CT angiography You can see up here, they are already pointing to a lesion. It's adjunctive. We don't really use it to rule out SCAD, but if you suspect it, then coronary CT angiography can really show these pictures well. I'm not showing the 3D images here, which are just beautiful, but this is that same spot here as in this area. So here's left main, and then as it kind of separates out into left anterior descending and left circumflex, you're seeing this portion here really higher up on that left anterior descending. And then you're seeing here where, excuse me, there's, sorry again, there's a little bit of blood and akinesis here on the distal portion of the left ventricle, and then okay, so that was basically it on that. But it's great as a non-invasive follow-up, so you can follow instead of going in and doing an invasive angiogram each time to see if they're healing, if that space is opening up. This is post, so this is later on. You're following up that same space that was dissected. Now you're looking at this and going, okay, yeah, that's now healed. Okay. So this is kind of the thought process in acute management. We'll start on this far column. If someone comes in with an acute spontaneous coronary artery dissection or SCAD, then if they're clinically stable and they don't seem to have any high-risk anatomy, how do we figure that out? Well, if they're clinically stable, typically you've gone to imaging, or you might have gone invasively in there, but conservative therapy. You monitor the patient, sometimes as long as 3 to 5 days. Sometimes you let them out a little bit sooner. It depends on what that SCAD looked like in the clinical course in the hospital for that patient. Here, if they're clinically stable, but they have left main or severe proximal two-vessel dissection, like it went into left anterior descending, left circumflex, then you might consider bypass. Conservative treatments may be reasonable, but we just don't know. I mean, there's no clinical trials. We're gathering the data now as to what to do. It makes people kind of pinch a little bit to think, well, do we treat this or do we not? And then if they have active ongoing ischemia, you've gone in, they're clinically stable, maybe? No, because they have some ischemia, they feel symptoms, or they're crashing. Blood pressure's dropping, heart rate's dropping. Then you consider upfront PCI, stent that person, or urgent bypass. So these are kind of the ways to think about when they present, what's going to happen. And it's important for you because then you can pick out that clinical picture as you're talking to the patient. They're, on the treadmill, like, hey, do you know what happened and what's your thoughts? And you might not give any recommendations, but you're like, yeah, it looked like this is, what it sounded like happened. Okay, so who do we revascularize up front? And that was that really third arm in this space here, this right column, active ongoing ischemia. So ongoing ischemia, setting of conservative management, and maybe they were hemodynamically stable, but they just, oh man, I have this ongoing pain, maybe because they have left main or proximal LAD. Question is do you do bypass up front or do you do it after you tried stent and it failed? But we've seen it first line as well, depending on how that left main looks or left anterior descending. So we have had some women under the age of 40 that have received single vessel bypass, and because they didn't want lifetime P2Y12 therapy. That's changed a little bit because the guidelines have changed where we could consider removing clopidogrel, prasugrel, or ticagrelor after the first year. But back in the day, we just kept them on lifetime P2Y12. So this might have changed some of this thought process. But, failure of grafts occur. If you have competition, whether the graft that you just put or, the regular native artery, if that heals, if there's competition of flow, then that graft will dry up. Okay, so imagine going, 215 and they put legacy in, and what if people didn't use legacy and over time they just kept using 215? Well, then maybe the city goes, okay, let's just get rid of legacy highway. So it's just one of those things that you think about physiologically what happens to these grafts. Okay, so invasive therapies, beyond revascularization, there's intra-aortic balloon pump, which we may use to help support the patient as they get through pregnancy, or a bridge to bypass. ICDs, like our 19-year-old patient who, she didn't present with sudden cardiac arrest, but some do, and so they may consider ICD up front rather than waiting 2 to 3 months to see what happens for that patient. Medical therapy. We do not treat this like atherosclerosis. As I said, these are not statinized patients, or at least you shouldn't, unless they do have comorbid atherosclerosis. But antiplatelet therapies here, you use, clopidogrel, ticagrelor, prasugrel for up to 3 to 12 months, kind of like the usual durations we do for stenting in atherosclerosis. Aspirin is very individualized. It's highly variable from 1 year to a lifetime. We just don't know. We don't know whether that's appropriate or not. And then beta blockers, again, limited to use it or not for these individuals. And I think we would probably consider them like current atherosclerosis, where if there's no LV dysfunction, maybe you just don't use it, or after the first year, you can stop it. Okay. Oops, let's see here. Oop. For some reason, okay, it is going forward. So, so ACE ARBs, if LV dysfunction is present, then, we would use it, but also if there's hypertension, we might use it. But remember, if this is a woman of childbearing age, ACE inhibitors and ARNIs and ARBs are all contraindicated, unless they've decided for tubal ligation or some other means of birth control. So because those medications can cause harm to the fetus. And then statin, again, it's not atherosclerotic. Antianginals, sometimes these are quite helpful as the SCAD, the dissection, heals. So they may have a role acutely in the hospital and during hospitalization, maybe for the next 2 to 3 months, but don't use it if it's not needed, right? Okay, so again, for those who have undergone a stent, it's just unclear harm of clopidogrel during pregnancy or breastfeeding. We just don't know because we don't do trials of using these medications in women who are pregnant or breastfeeding. It's generally, we just don't know. Low-dose aspirin is safe during pregnancy and breastfeeding. Beta blockers, we would use labetalol if we need hypertension management for these women. Okay, to the important part. Drum roll, please. Cardiac rehab. The ball is in your court, right? All MI patients who have had SCAD, like other MI patients, you individualize and tailor therapy. It's just so wildly different from an MI population because they're generally not older. These are younger patients who are a little bit more athletic to begin with, and maybe it was the sport event that led to the SCAD. So they're younger, activities are higher. Remember that the majority are of childbearing age, and they may have children and daytime home responsibilities, or they're working. They're out there, they're trying to juggle all of this, and you're saying, hey, come to cardiac rehab 2 to 3 days a week. This is a problem. We need to make it easier for our patients, all patients, but in particular, these are women that we're trying to get back on the road to health. So, in hospital, in the outpatient after cardiac rehab, what is our recommendation? Don't lift greater than 10 pounds? Limit activity to walking? Are you serious? It's hard. I struggle with this because, again, there is no day that I'm not lifting something over 10 pounds. And that's just usual activities. So that was my question is, do you lift something over 10 pounds on any given day? If it's a woman of childbearing age or a young woman with a child, you think that child's not going to get over 10 pounds. Cardiac rehab is the testing ground. You're going to learn a lot, but you're going to learn a lot from your patients. These are previously active patients. They will chafe with restrictions that you give them. You know these things. In the orthopedic side, as an athletic trainer, oh my gosh, athletes continually push on our conservative restrictions on them. And this is a push and pull. We really have to be reasonable, but we have to listen to our patients. Here is the guidance from the Vancouver General Hospital SCAD program. I think this is reasonable. They have a lot of data here, observational, and they're keeping track of this prospectively. So try to, this is like normal. I tell my patients, keep your blood pressure less than 130/80. So it's reasonable to think of these things. Heart rates, maybe in the beginning, target heart rates are lower, right? 50 to 70 instead of like 60 to 70 of reserve. And then start low. Just, let's get your heart ready for this. Let's let it heal. And then time will tell as you increase the weights. Strength training here, consider low weight, high reps. Try to avoid strain in Valsalva. So maybe up to 20 pounds in women, 50 pounds in men. I think that's a little bit sexist, I think, but it really is the patient in front of you, okay? Consider cardiopulmonary stress testing to hone in on individual responses and assess where the anaerobic threshold is. And that will help you to assess exercise-induced hypertension. Bottom line, we don't have any research evidence. We just don't. We're all walking in the dark here. Let's walk together with our patients and make the restrictions or limitations or recommendations make sense, okay? So cardiac rehab. What about blood pressure and heavyweight lifting? This is single arm curls. This is with an art line in and checking to see just how high the pressure gets. 255 over 190. Double leg press, 320 over 250. And one subject went 480 over 350. It's actually amazing to me we don't have more dissections occurring. But what that tells us is that we're an amazing piece of biologic machinery. We don't know. But what we do know is pressures can get really high. So be careful, be aware, and think about this with your patients. So we advise SCAD patients to avoid or at least minimize exposure to. It's so difficult to say, stop all these things. But you can say, look, let's just make it make sense. You want to survive. We want you to survive. But let's make it common sense. They're anxious. They're living in fear. How do we navigate this together? Try to avoid prolonged high-intensity exercise. So HIIT might be, high-intensity interval training, high competitive or contact sports, activities that are performed to exhaustion, abrupt starts and stops without at least warming up, and then extreme weather terrains. And then I think Valsalva is probably the most important. Kind of try to breathe through activities and what you're doing. Patients should be counseled against isometric or extreme exercise, but as a causal association between lower levels of exercise and SCAD has not been established. Given the mental and physical benefits of exercise, a return to full activity following SCAD, including non-extreme sport, is reasonable. They're saying two things. Counsel against isometric or extreme exercise, but really, return to full activity if you can, because we just don't know. Cross studies, 7 to 40% report a baseline history of depression. Look, you're telling me that we are not sure why I had this event, that I have high likelihood of recurrence from 10 to 30% in the first 2 to 3 years, 15 to 37% in 5 to 7 years, and half, 50% at 10 years. And we're not sure what prevents it, that I can't resume my previous level of physical activity. Yeah, of course I'm depressed. I'm anxious. Okay, that's really the context that we should receive these patients. PSCAD, repeat pregnancy, is generally not advised. They'll choose to, and we have to walk into that with them, but please get your maternal fetal medicine partners involved, okay? And then consider referring them soon to the SCAD Alliance. poke at it. Go to scadalliance.org. It's a great place for you to learn as a provider what patients are experiencing. This is really, I mean, I'm not going to go through this entire thing. We kind of did in, the left, middle, right columns, but this is the evaluation of management and management of chest pain after SCAD. So they've had a SCAD event and now they're coming in with another chest pain event. What do we do? How do we manage these folks? Is it SCAD? Is it STEMI? Is it, what's going on here? And so I'm going to leave this with you to kind of look at on your own, but this is what I want to leave you with. It's a lot here. Okay, patients with SCAD and FMD, they remain at risk of recurrent vascular dissection because of those shear forces. There's a mutation there for FMD, but SCAD also. So extreme or unusual exercise triggers can be a trigger for SCAD in up to 29% of those patients. So there's higher risk. We just don't know which patient, and we don't know if that's always the case, right? But exercise in general, it's important for all of us. It's how I get into the right headspace. This morning, I woke up at 4:40, got to the gym, did my thing, did another meeting before this meeting. But it got me into the headspace that I need to be. Don't stop people from exercising, but make sure it's reasonable. Aerobic training is okay for them. With the limited data that we have, I think you can reasonably say, look, start into it. We can watch you. This is the importance of cardiac rehab, and then we can help you launch back in. Okay. They should use proper breathing and lifting technique. So should we all. Just avoid things that cause Valsalva. There's just no data here for riding roller coasters, skydiving, scuba diving, or yes, importantly, sexual intercourse. We shouldn't advise against it. We just don't know. And I have this conversation and I bring it up so that they don't feel embarrassed. Especially here in a conservative environment, people are embarrassed to talk about those things related to intimacy, sexual intercourse, and whether it's important, whether they can or can't. So we should invite those conversations. That's really the end here. I don't have anything else. I wanted to leave a little bit of time, sorry, not a lot of time here, for any questions that the audience might have.
Anybody have any questions?
I answered all things.
You've taught us so well that nobody has any questions.
Well, you know what they say. You can dazzle them with your brilliance, or baffle them with your BS. And hopefully I didn't gish gallop my way through. No ability to, ask any questions of me. But just know that we're together in this. Please reach out. I'm on Teams for those at Intermountain. Ask me questions. I'm always happy to answer them to the best of my knowledge. And if I don't know it, we'll work together to find out what's best for our patients that we treat. Okay.
Thank you, Viet. Viet, you are wonderful. We always love learning from you. And I think that this will provide better quality care when we do have our SCAD patients, the few that we get that come through. So everybody give it up for Viet. Okay, guys, give us about 5 minutes. We're going to switch out and get the next presenters ready to go, okay?